This clinical lesson is in regards to postural control following episodic, acute, and/or chronic low back pain in comparison to healthy controls. So the mechanisms that have been proposed have been kind of shown here. So you have the incident of low back pain, you have adaptations to motor control, which the authors here have categorized into motor behavior, motor system, proprioception, and psychological factors. Our focus today is on the proprioceptive component, and then you can have the models of motor adaptation. So reinforcement of learning or redistribution. I want to try and keep this relatively simple and focus on the trunk motor variability with a tight control versus a trunk motor variability with what they term a loose control, and how this can have long-term implications on the increased spinal loading and potentially long-term consequences of intervertebral discs and other tissues. I encourage you to see the references of this presentation for further detail here. All right, so here's a simplified schematic of how altered motor variability can lead to persistent pain and low back pain. So on the y-axis you have low versus high. On the x-axis you have time, where you have the first half in like acute low back pain, and you have recurrent and or chronic or episodic shown in B shaded region. And then on the opposing y-axis you have pain, no pain, and then pain again, suggesting that those individuals that have high motor variability and or low would be predisposed to having more symptomatology due to the additional stresses on the non-contractile soft tissues of the spine. So you have three lines. So the first solid line is the one that is ideal, where following the initial onset of low back pain, that individuals would have a loose control. They would have higher motor availability due to the avoidance of fatigue and or finding positions that would otherwise be non-provocative. And then this is the most ideal scenario, where after the reduction of pain, that they then go back to more of this midline variability leading to no pain. However, you have these other two scenarios where individuals will, if we focus on the dashed line, will not as readily come back to more middle of the road motor variability, and thus can have a more persistent onset of their pain. However, it will gradually diminish. And then you have this other cohort that doesn't really adapt initially to having more variability, and they will eventually become much more rigid and restrictive in their movement patterns and their postural control strategies following low back pain. And you can see that this will lead to lower motor availability, lower movement options, and thus stressing the non-contractile tissues of the spine, leading to persistent pain in either chronic, recurrent, and or episodic low back pain. So let's look at some clinical examples briefly. So I'll let you choose or try to identify which person
The leg
has
stance.
a history of low back pain.
Okay, can you go hands on hips? Other leg. The leg stance. Okay.
So you're looking at single leg stance, eyes open. Individual on the left has history of low back pain, about 18 months previously. He had a disc equestration, and then the person on the right has no history.
Okay. Opposite limb. Other leg. The leg stance. Okay, can you go hands on hips? Other leg.
Notice the high motor variability in that first individual, and additional strategies that he's attempting to use in order to be able to sustain the static postural control. Same individuals, eyes closed. So taking away the forcing proprioceptive component.
Eyes closed. Eyes closed. So find your balance, eyes
first,
open.
and then go ahead.
Then eyes closed. Nice. Can you go hands on hips? Same thing. Other side. Eyes closed. Very good.
So the mechanisms at play here is that after the altered proprioceptive input coming up from the spine, that there can be a sensory reweighting that has been shown. Again, I encourage you to check out the references where they describe the individual relying much more on their visual motor system rather than on their sensory motor system in order to sustain their postural control during static, and you'll see in a moment dynamic activity.
Eyes closed.
So in the presence of visual perturbation, so not eyes completely occluded, but rather you can see the glasses here that will be flashing, giving them only partial visual input, also known as visual perturbation.
Leg stance. Same thing. Don't worry about the hands on hips. Hands on however hips.
you want them.
Just like you were. Great. Other limb. Try and go 10 seconds.
All right, can we do the palms out one more time?
Same thing. Don't worry about the hands on hips, but however you want them. Right leg. And don't worry about the hands on hips. Go wherever you naturally would go. Great. Other limb.
The goal is to kind of check that.
And drop that upper shoulder.
So much more difficult for the individual with the persistent low back pain in order to sustain these positions. He demonstrates well below his demographic age predicted norms for eyes open and eyes closed. Okay, dynamic tasks. Notice the flexion synergy that is noticed within the upper extremities of the individual with persistent low back pain versus the individual without low back pain eventually finds a strategy of reciprocal movement such as that seen in gait. So here's the reciprocal arm movement going with the opposing limb versus individual with low back pain. Doesn't necessarily find that synergy and consistently uses their flexor synergy musculature, such as their adductors, their flexion of their elbow, and then eventually you'll find that the repetitions where he's more successful is that he starts to grip versus, again, our individual without low back pain. Very fluid movement, hands open, not so much into the flexion synergy. Look at the arm here and the fist. And then as he goes into the lateral movement, again, closed fists, elbow flexion, hip adduction. You can tell this individual to engage their glutes more, but you're really just hiding the issue rather than solving it. Right? Even put a band on them that gives them a little bit of an external cue. But he's still in the flexion positioning. And then the reciprocal pattern here in the arms and the legs, such as seen in a gait pattern, but does not have that reciprocal control in the individual with persistent low back pain. So here are the references that I utilized. I encourage you to check them out. And this is the lesson for today. I encourage you to consider the postural control deficits in the individual with acute, chronic, episodic low back pain. Rather than just focusing on the core, there's much more to it than that, and how the brain reorganizes and reweights itself following injury.